Bismillah ar-Rahman ar-Rahim. Hello and welcome to my lecture series in Obstetrics and Gynecology, Dr. Azdihar Sahmi Hamoodi. Our lecture today is Induction and Augmentation of Labor. You can find this subject in your book 10 Teachers, Chapter 12, Normal and Abnormal Labor, Subject Induction of Labor, page 455. Learning objectives that you must know in this lecture are definition of induction and augmentation of labor, indications and contraindications of induction of labor, what are the preparations of induction, and different methods of induction, objectives that are nice to know, the processes of induction in sequence, the dose and route of drugs used, and the care of higher risk pregnancies. What are the definitions of induction of labor and augmentation of labor? Induction of labor is defined as artificial stimulation of uterine contractions before the onset of labor. It is an obstetric intervention that should be used when elective birth is beneficial to mother and or baby. Augmentation of labor, on the other hand, refers to stimulation of spontaneous contractions that are considered inadequate because of failed cervical dilatation and fetal descent. So, it is intervention to correct slow progress in labor. What are the indications of induction of labor? It is indicated when the benefits of delivery to the mother or fetus outweigh those of continuing with the pregnancy. When delivery will be of benefit to the health of the fetus or mother or both. The risks of induction of labor should be weighed against the benefits of continuing with the pregnancy. Indications. What are the maternal indications? Post-term, main indication, pregnancy-induced hypertension, timing depend on the severity of hypertension, diabetes mellitus, because diabetes mellitus increase risk of baby loss and its mortality, medical conditions, for example, renal, respiratory, or cardiac diseases, unexplained antepartum hemorrhage, placental insufficiency, moderate or severe placental abruption, but commonly these complications end with the cesarean section. Prolonged pre-labor rupture of membrane, that's to say PROM or PPROM, with risk of chorioamnionitis, RH isoimmunization, and finally maternal request. What are the fetal indications? Suspected fetal compromise, that's to say intrauterine growth retardation, intrauterine death, intrahepatic cholestasis of pregnancy, and twin pregnancy continuing beyond 38 weeks. What are the contraindications? Placenta previa and vasa previa, as you see in this picture, abnormal fetal lie or presentation, for example, transverse lie and breech presentation, umbilical cord prolapse and fetal distress, previous classical cesarean section, active herpes infection, pelvic structural abnormality, invasive cervical cancer, or contraindication to drugs that's used for induction of labor. We have also several situations where the induction of labor is not a true contraindication, but we can do it with caution. For example, multiple pregnancy, polyhydramnios, grand multiparity, maternal heart disease, severe hypertension, breech presentation, previous cesarean section, and abnormal fetal heart rate not requiring emergency cesarean section. What are the maternal risks for induction of labor? Failure leading to cesarean section, uterine hyperstimulation, rupture uterus, intrauterine infection, that's to say chorioamnionitis, amniotic fluid embolism, precipitate labor or dysfunctional labor, increased risk of operative vaginal delivery, increased risk of postpartum hemorrhage, abruptio placenta, antepartum hemorrhage from undiagnosed placenta previa, or water intoxication from drugs, that's to say oxytocin. What are the fetal risks? fetal distress, fetal death, neonatal sepsis, iatrogenic delivery of a preterm infant, cord prolapse, neonatal jaundice, and increased risk for birth trauma. Parameters to assess prior to induction of labor. For the mother, to confirm the indication for induction of labor, exclude the contraindications. Assess Bishop score. Bishop score more than 6 or more than 6 is called favorable cervix. Assess adequacy of the pelvis and fetal size. Adequate counseling about the risks, benefits, and alternatives of induction of labor with the woman and her family. That's to say, family counseling. Parameters for the fetus to ensure fetal gestational age, to estimate fetal weight, ensure fetal lung maturation, ensure fetal presentation and lie, and to confirm fetal well-being. Time, place, and preparations. The time of induction, preferably early morning, and the place of induction where facility for intervention and fetal monitoring is available, as you see in this picture. So when induction of labor is indicated and you will induce the mother, uterine activity and fetal heart rate should be continuously monitored. So in case of clinical auscultation, fetal heart rate should be heard during and for 30 seconds after contraction, at least every 15 minutes, or you can use electrical fetal monitoring. Partogram is to be maintained for active labor. Trained personnel and well-equipped center must be found. This slide shows you the Bishop score in induction. It's used to determine the favorability ripening of the cervix in vaginal examination. So if the score is high, that means the cervix is favorable and the induction will be easier and shorter. If the Bishop score is low, that means that the cervix is unfavorable and induction of labor will take longer period and more likely to fail and end with emergency cesarean section. This picture shows you the sequence of cervical dilatation and effacement in the second part of the first stage of labor. This slide shows you the mechanism of initiation of labor, naturally, endocrinology of labor, hormones that affect the cervix to increase prostaglandin and stimulation of uterine contraction. So we have 4 methods for induction of labor. These are natural, non-medical methods, mechanical methods, surgical methods, and pharmacological methods. So, first, the natural, non-medical methods. Relaxation technique. You will advise the patient to relieve tension and try to relax. Then use some visual aids to show how labor starts. By visualization, the patient is advised to imagine her uterus contracting and she is laboring. This is called hypnosis or self-hypnosis, will help to initiate contractions. Walking, as you see here, the force of gravity pulls the weight of the baby towards the birth canal, leading to dilatation and effacement of the cervix. So we always advise these patients to walk. Having sex is not to induce labor. Why? Because there is relation between the having sex and prostaglandin content of the seminal fluid, and the occurrence of orgasm also stimulate the uterine contractions. Nipple stimulation. The lady moves her palm and applies some pressure in a circular fashion over her areola, and massaging nipple between the thumb and forefingers for a period about 2 minutes and rest 3 minutes. If contraction is not enough, she can repeat it with 3 minutes stimulation or massaging and 2 minutes rest. but she should avoid massaging during contraction because of side effect of hyperstimulation, uterine hyperstimulation and contraction. Kamun tea, used by midwives also as a natural way for initiation of contractions. The same for several herbs. Acupressure. There, they found that there is association between some acupressure points in the body and increased uterine contractions. One point is located deep in the webbing between the thumb and forefinger, as you see here. And massaging of this point in a circular motion for 1 to 5 minutes will stimulate labor pain and induce labor. Now we have the mechanical methods. For example, hygroscopic dilators. They absorb endocervical and local tissue fluids, causing the device to expand within the endocervix and provide mechanical pressure. These dilators are either natural osmotic dilators, for example, laminaria, or synthetic osmotic dilator, for example, Lamisil. As you see here, this before insertion, this is after insertion, becomes wide, large, that cause mechanical pressure on the endocervix, help to dilate the cervix. What is the advantages? What are the advantages of these dilators? It's outpatient placement. You can put it, insert it in outpatient clinic. There is no need for fetal monitoring. But the risk is for the fetus and or for the mother is the infection. There is a risk for infection. The second mechanical method is placement of balloon dilators. Fluid-filled balloon is inserted inside the cervix. The balloon provides mechanical pressure directly on the cervix, which respond by ripening and dilation, as you see here. It's either Foley catheter or specifically designed balloon devices can be used. So you see here is a Foley catheter. Surgical methods. We can use stripping the membranes or what's called membrane sweeping. Stripping the membranes mechanically dilate the cervix, which release prostaglandins. The membranes are stripped by inserting the examining finger through the internal os and moving it in a circular direction to detach the inferior pole of the membranes from the lower uterine segment, as you see here in this picture. What are the risks of the sweeping membranes? Patient's discomfort, infection, bleeding from undiagnosed placenta previa or low-lying placenta, accidental rupture of membrane. But you see here, uh, uh, they they um, they the reviewers see that they concluded that the stripping the membranes when used as a adjunct, that's to say as help mechanism in induction, decreases the mean dose of oxytocin needed and increase the rate of normal vaginal deliveries. So it is a very useful way and we use it oftenly in induction of labor. Another surgical method is amniotomy. The fetal heart rate is recorded before the procedure, and pelvic examination is performed to evaluate the cervix and the station of the presenting part. The presenting part should be well fitted to the cervix. The membranes are identified and a cover is inserted through the cervical os by sliding it along the hand and fingers, and membranes are ruptured, as you see here this picture. Nature of amniotic fluid is recorded. We can see the fluid if it's clear, bloody, thick, thin, or meconium stained. Then the fetal heart rate is recorded again after the procedure. So you see fetal heart recorded before the procedure, fetal heart is recorded after the procedure. Why we do amniotomy? It's performed to induce labor, to augment contractions, shorten the duration of labor, and visualize the color of liquor, as we said before, or to attach a fetal scalp electrode, that's to say the internal way for fetal heart registration, CTG. When we do amniotomy, artificial rupture membrane done when the cervix is favorable, so the Bishop score must be high. What are the risks of amniotomy? Prolapse of umbilical cord, infection, chorioamnionitis, postpartum hemorrhage, risk is doubled with women of spontaneous onset of labor, rupture of vasa previa, and neonatal hyperbilirubinemia. Now, the last methods are pharmacological methods. Prostaglandin E2, dinopristone, inserted vaginally as gel, for example, Prepidel, or as removable tampon, what's called Cervidel, as you see here, or Pessary. It acts on the cervical connective tissue and relaxes muscle fibers of the cervix. Dinopristone should only be administered at hospital, and the patient is expected to stay recumbent and monitored, at least for the first 30 minutes after insertion. Contractions usually start within 60 minutes of commencing induction and peak with 4 hours. If optimal response is not achieved by 6 hours, we can repeat the dose after 6 hours. The maximum allowed doses are only 3 doses per 24 hours. That's to say, every 8 hours. Cervidil, as you see here, contains 10 milligram of dinopristone, that's to say prostaglandin E2, to provide a lower constant release of medication. So it releases the medication continuously, about 0.3 milligram per hour. Cervidil have the advantage of being removed more easily if uterine hyperstimulation occurs, so you can pull it when you need. It does not require refrigeration. Keep in your mind, prostaglandin E2 can cause uterine hyperstimulation, fetal distress, and cesarean section. So be aware of it. Before interventions, what will you do before you insert prostaglandin E2? Review patient's history before administration to ensure that there are no contraindications or any caution for these drugs for induction of labor at all. Fetal heart rate and uterine contraction should be monitored continuously for 30 to 60 minutes after administration. There is a risk of uterine hyperstimulation and rupture of uterus with or without fetal distress. Instruct women before you insert this medication to pass urine before administration of prostaglandin. Why? Because she will stay for a long time in bed. She should remain in lateral or supine position on withheld tilt for 30 to 60 minutes after administration of gel and about 2 hours after insertion of vaginal tablet. Why she should be in this position? To minimize leakage and improve effectiveness of the drug. Assess cervical dilatation 6 hours after insertion. If no cervical response and no adverse effect, you can repeat the dose. Monitor the side effect of prostaglandins, for example, pyrexia, warm feeling in the vagina, vomiting, diarrhea, and backache. It is necessary to allow at least 2 hours to elapse between the last prostaglandin dose and the starting oxytocin or syntocinon infusion if you decided to put infusion oxytocin, you should wait 1 to 2 hours. Why? Because prostaglandin increase the sensitivity of the uterus to syntocinon. So there will be a risk for uterine hyperstimulation. If any adverse reaction occur, notify doctor to remove the gel or suppository if possible. We have another medication, another pharmacological method, which is misoprostol. Misoprostol is synthetic prostaglandin E1 analog. The route of administration is either oral, vaginal, or sublingual route for induction. Rectal route is used to prevent and treat postpartum hemorrhage only, not for induction. They have observed that peak plasma concentration is higher and achieved earlier after an oral administration. The peak level with vaginal administration are attained more slowly and sustained for longer periods because of the pre-systemic gastrointestinal and hepatic metabolism that occurs with oral route. Overall, the systemic bioavailability is 3 times higher with the vaginal route. So we have misoprostol, which is called Cytotec, which is synthetic prostaglandin E1 analog, has been found to be safe and inexpensive agent for cervical ripening. It does not require storage conditions. Misoprostol shorten the induction delivery interval as compared with the prostaglandin E2 and oxytocin. Tablets are available either 100 or 200 microgram. So you see here, it is okay, it is good, but the dose required for initiation of labor or induction of labor is only 25 to 50 microgram. Actually, it's only 25 microgram that needed for induction of labor. Administrated 4 to 6 hourly. We can repeat it 4 to 6 hourly. So we cannot use the tablet of 200 microgram because it's a high dose. We use it only for termination of unwanted pregnancy, for example, abortion or miscarriage or even intrauterine death, but not for viable pregnancy, for cervical ripening for induction of labor. But we have this type of medication in this dose. That's to say 25 microgram. It's called Vagiprost in our country. We have Vagiprost, which is misoprostol, prostaglandin E1, 25 microgram tablet. So we can use it in cervical ripening for induction of labor, but not the Cytotec of 200 microgram. Keep it in your mind. The tablet is inserted into the posterior vaginal fornix, and one may or may not wet this tablet with saline or water prior to the insertion for good effect, of course. We have another drug which is called mifepristone. Mifeprex, is an antiprogesterone agent which counteracts the inhibitory effect of progesterone on the uterus. Few studies with a small number of women enrolled have shown that women treated with mifepristone in a dose of 600 mg are more likely to have a favorable cervix and deliver within 48 to 96 hours when compared with the placebo, and they less likely to undergo cesarean section. But information about fetal outcomes and maternal side effects is scarce and cannot be used to recommend the use of mifepristone for cervical ripening. That's why mifepristone used only for um, termination of unwanted pregnancy, again like abortion or miscarriage, missed abortion, or we can use it even with IUD, but not for cervical ripening for induction of labor with a viable fetus. So we have another type of medication, oxytocin or syntocinon. Syntocinon is a synthetic version of oxytocin. Oxytocin is a hormone secreted by posterior pituitary gland. It is a neuropeptide synthesized in supraoptic and paraventricular nucleus of the hypothalamus and released into the posterior pituitary gland. It's commonly used drug for induction of labor in form of dilute solution, that's the infusion. Its half-life about 3 to 4 minutes and effects last for 15 to 20 minutes. After intravenous infusion, uterine response occurs within 3 to 5 minutes, so it's short acting, and steady state plasma concentration is reached in about 40 minutes. Starting dose of syntocinon about 1 to 2 milliunit per minute, and the dose should be increased at interval about 30 minutes. Uterine action and fetal heart sound monitored. Dose is increased gradually as per uterine action and fetal heart rate till we reach 3 to 5 contractions in 10 minutes. Syntocinon drip is stopped if there are signs of fetal distress. It is necessary to maintain the drip after delivery for at least 2 to 3 hours. Why? It's a prophylactic to avoid delayed postpartum hemorrhage. So we use it to enhance uterine contraction. Oxytocin infusion pump can regulate the dose of a drug and control the uterine action effectively, as well as limits IV fluids. So the pump, if you have pump in the casualty room, it is the best, better than ordinary IV line. This schedule show you the dose increment of oxytocin for using for induction of labor. What are the side effects of oxytocin? Uterine hyperstimulation, abruptio placenta, water intoxication, and hypotension. What are the signs of hyperstimulation of uterus? Contraction occur more frequently than every 2 minutes. The duration of contraction is longer than 90 seconds. There will be elevation of resting tone of uterus, will be greater than 15 to 20 millimeter of mercury over the baseline. The blood pressure increases when contractions increase in frequency, duration, and intensity because of decrease in uteroplacental circulation. There will be increasing in pain because of increased frequency, duration, and intensity of uterine contractions. Sustained tetanic contractions can occur also. What are the signs of fetal distress? There will be tachycardia or bradycardia, late decelerations, variable decelerations, or prolonged decelerations, any type of deceleration, loss of variability, excessive molding or caput formation, and meconium stained amniotic fluid. Well, with this slide, I will finish my lecture. I would like to thank you very much. Thank you for your attention. I wish you a good luck in your study and goodbye.